Hello, and welcome to this week's podcast brought to you by VJOncology. Today, we're joined by Javier Martín-Broto, a leading expert in sarcoma from Fundación Jiménez Díaz University Hospital in Madrid, Spain. To begin, Dr. Martín-Broto discussed the nuanced role of immunotherapies in sarcoma, highlighting how certain subtypes, such as alveolar soft part sarcoma, demonstrate immunosensitivity despite most members having a low tumor mutation burden and a cold microenvironment.
In general, we can say that sarcoma is not a good field to recommend immunotherapy because sarcoma in general is exhibiting a cold microenvironment. For instance, in terms of tumor mutation and burden, the median sarcoma is 2 mutations per DNA megabase. So it's clearly far away than other tumors more sensitive to immunotherapy as melanoma, which has 14 mutations per DNA megabase, for instance. But it's also true that there are some specific sarcoma subtypes that, despite a cold microenvironment, can exhibit sensitivity to immunotherapy, which is the case, for instance, of alveolar soft part sarcoma, for which we have already tezolizumab, a drug approved by FDA. So maybe the relation between immunosensitivity and alveolar soft part sarcoma is not relied on the normal variables that we are using in other tumors as the case of melanoma, and probably TFE3, which is a part of the translocation of the fusion transcript in alveolar soft part sarcoma, is in relation to maturation of immunogenic synapse. And on the other side, there are recent experiences targeting the concept of immunogenic cell death, and that based on this property that have some chemotherapeutic agents as doxorubicin can be enhanced the influence of this kind of dian cell with anti-PD-1, for instance, which is the case of leiomyosarcoma and UPS and other more common sarcoma subtypes. And also we have, obviously, the TCR-T cell therapy experience in synovial sarcoma and also in myxoid liposarcoma. So in general, even when the general concept is, okay, sarcoma is a cold microenvironment and then there is no room for immunotherapy, but I will persuade you that there are several niches for which immunotherapy is extremely useful in the sarcoma context.
Dr. Martín-Broto explains the potential of combining anti-PD-1 or anti-PD-L1 agents with anti-angiogenic or anti-CTLA-4 therapies. These combinations have demonstrated improved response rates and longer progression-free survival compared to monotherapy.
Considering the primary challenges that we are facing with immunotherapy in sarcomas, obviously one of them is the microenvironment. The microenvironment that is found in sarcoma is clearly cold microenvironment, with some very few exceptions. Maybe 15% of angiosarcoma can have more than 20 mitosis per DNA megabase. Or some UPS, for instance, a proportion of 15% of UPS patients can exceed larger number of mutations. But in general, the microenvironment is cold. So one of the strategies that have been used to overcome this resistance is the combination of anti-PD-1 or anti-PD-1 compounds plus another type of compound that can be anti-angiogenic. For instance, this is the case of pembrolizumab plus axitinib, or the case of sunitinib plus nivolumab, or maybe the combination with double hit or double immunocheck inhibitors, which is the case of anti-CTL4 plus anti-PD-1, which is the case of ipilimumab plus nivolumab. So with these strategies, trying to inflame the cold microenvironment in the sarcoma, it seems that the overall response rate is higher than just anti-PD-1 or anti-PD-1, obviously by indirect comparison. And also the median of progression-free survival is longer than just monotherapy. This is obviously extrapolation, and it's difficult to compare studies because the inclusion criteria varies across the different studies. So it's difficult to withdraw robust conclusions. But the feeling of these studies is that probably the combination with anti-PD-1 or anti-PD-1 plus anti-angiogenic or anti-CTLA-4 is more convenient in terms of overall response rate and in terms, at least, of a longer progression-free survival. And then this is a logical approach because the neoangiogenesis prevent the immune adaptive response. So blocking the neoangiogenesis can facilitate the role of the inhibitors of PD-1 or PD-L1 immune checkpoints. So another option, very, very topical issue, is the combination of chemotherapy based on anthracyclines plus anti-PD-1 or anti-PD-1. This is something relatively recent in the last 2 years and recently have been published in JCO the experience of phase 1b with the combination of doxorubicin, dacarbazine plus nivolumab in the context of first line of advanced leiomyosarcoma patients. So the overall response rate in this case was 56%, which is more than double than reported with the combination of doxorubicin plus dacarbazine. And the median of progression-free survival was almost 9 months, which is by indirect comparison seems to be longer than just monotherapy. But it's true that this scheme, this approach has one important vulnerability, is that in the maintenance phase with just anti-PD-1, it's not enough for disease control because the majority of progressions are seen in the early phase of maintenance with anti-PD-1 compound. So we need to improve this phase. But in terms of overall response rate, and it seems very, very powerful. And we will present this year in the ASCO meeting the cohort of undifferentiated pleomorphic sarcoma, also with this concept of chemoimmunotherapy with epirubicin, ifosfamide plus nivolumab. And this will be also interesting to discuss in the context of the ASCO meeting. And last year, also in ASCO meeting, Chinese colleagues reported the experience of chemoimmunotherapy in other sarcoma subtypes, including UPS, but also the differentiated lipo and other subtypes. And again, the overall response rate was above 60%. So this strategy seems to be very, very powerful, and this seems to overcome the cold microenvironment in this context. And of note, in our team demonstrated that the HMTB1, which is a canonical biomarker of immunogenic cell death, increased over time in the prospective trial that I have mentioned of doxorubicin, dacarbazine plus nivolumab. And more importantly, the increase over one threshold was correlated with a longer progression-free survival. So it seems that this concept it should be exploited in the upcoming comparative studies, and especially in the high-risk localized disease where chemoimmunotherapy plus radiation therapy, which can also add value for immunogenic cell death, maybe will represent a qualitative jump in the cure of this subset of patients.
He then highlights promising results with TCR-T cell therapy, particularly in patients with synovial sarcoma and myxoid liposarcoma.
There are some experiences with TCR-T cell therapy, which is a kind of immune cell therapy in sarcomas. Obviously, the initial experiences focused on synovial sarcoma, which express usually NY-ESO1 and also MAGE4, and the same for myxoid liposarcoma. So there have been single-arm clinical trials reporting a very interesting activity in terms of partial responses. It's true that the majority of these patients can be treated with several previous lines. So some of the patients enrolled in these trials were heavily pre-treated patients. And despite that, a substantial proportion of patients responded to this strategy. So I think this is also an option. It's true that the limitations is the restriction of HLA subtype and also the expression, obviously, of the antigen and YSO1 or MAJ4. And in total, more or less 15-20% of patients with synovial sarcoma or myxoid liposarcoma could be treated with this strategy. But it's also true that fine-tuning the options for the patients with this strategy, maybe my recommendations would be to treat in an earlier phase, these patients, maybe in the oligometastatic disease, or even in the high-risk localized disease. Why not? Can be very, very interesting to treat these patients. So the phase 2 trials have reported substantial activity around 50%, and the proportion of patients with this shrinkage was even higher. But it's also true that in the end, the duration of the responses being adequate is not the expectation. This was less than expected. So I think there is an option for sure for these patients, because some of them, especially those with lower tumor burden, can be benefited. And then I think it's an option. But still, we need to fine-tune the recommendations, and maybe the very late phase is not the best option for TCR-T cell therapy.
Dr. Martín-Broto pointed to tertiary lymphoid structure, TLS, as a robust biomarker of immunotherapy response. However, he notes challenges in detection in a relatively small proportion of patients who express this feature.
It will be very, very crucial investigation about predictive biomarkers. And in this sense, tertiary lymphoid structure seems to be the most robust biomarkers of immunotherapy in sarcoma context, and several publications reported from Petitpré and Antoine Italiano seems to be very, very, very important. The presence of TLS detected by pathologists is clearly correlated with a higher probability of response in these patients. So this is beyond any doubt. What is the limitations of TLS? The first limitation is that maybe the technique can vary, and we will need expert pathologists in detecting this TLS, which is the presence of mature dendritic cells, CD3 lymph cells, and B cells, CD20 positive cells. So maybe we will require some time for this training from the pathologist, because this can be obviously a limitation, but it seems it's not highly complicated, let's say, and we will use in the upcoming months as a standard approach for advanced setting. Another option is true that the TLS proportion of patients that can be detected, or the estimation is around 20% of sarcoma patients can express this biomarker. So maybe 80%, the remaining 80%, some of them can respond to immunotherapy. So we have developed as well a genomic signature that can be predictive for immunomodulation in the context of soft tissue sarcoma. And this is a 7-gene signature that have been built considering those dynamic changes in gene expression from baseline to week 13 in the immunosarc trial. And then the signature was also validated at baseline, which is able to predict the different progression-free survival, and we have validated this signature as well in the SARC trial of patients treated with pembrolizumab. So maybe genomic signature will be very convenient as well in order to establish a higher probability of activity with immunomodulation. Actually, with this 7 gene signature positive, the median of progression-free survival is above 11 months. But if it's negative, it's below 2 months. So this seems to be very powerful in distinguishing two different populations. So, and the validation also detected two different populations, but with these clear, different polarized figures. So it's obviously this is a very important field of knowledge because, as I mentioned, some patients with sarcoma can be benefited even with exhibiting a cold microenvironment. And then we have the chemoimmunotherapy, as I mentioned before. And for this specific strategy, we don't have any prediction. Still, we don't have any prediction, but this will be very important. We have the dynamic prediction, and we can say that after 2 months, the increase in blood of HMGB1 predicts longer progression-free survival, for instance. So, but still, this is not at baseline. It's after 8 weeks. Okay. So, but the knowledge is increasing in the recent times, and I think this will be very, very interesting. Also, the Milan team, Sandro Pasquali, has recently reported the convenience to explore in the high-risk localized disease different areas in the surgical specimen after neoadjuvant chemotherapy. And in those areas called high inflammatory, it seems the performance of this scoring of this area is good enough to predict significantly better disease-free survival, for instance. And again, this is a dynamic changes, but at the time of surgery, we can say to the patient, okay, this seems to be good enough for thinking that the disease-free survival will be good. So this is obviously a very topical issue, and several investigators are dedicating a huge effort in defining predictive biomarkers of immunomodulation in the sarcoma context, and this is obviously very welcome.
Thank you for listening. We hope you enjoyed this podcast. To stay up to date with the latest news in oncology, subscribe to our weekly podcast on Apple Podcasts, Podbean, or Spotify. Follow us on X, formerly Twitter, at VJOncology to join in the conversation. And make sure to check out VJOncology.com for the latest updates in sarcoma.